Welcome, everyone, and thank you for joining us today for the final inHEART webinar of 2025 to discuss from innovation to standard of care inHEART in daily practice. We're thrilled to share that we've had over 90 people register for today's event. And today we are joined by Dr. Henry Shaw from UCSF, Dr. Heidi Estner from Munich. In addition, we're joined by guest panelists, Dr. Wu from Southwestern Medical Center in Dallas, and Dr. Jakobsen from Copenhagen. My name is Katie Arnold, and I will be moderating today's conversation along with my colleague, Kelly Hamburger. We will be recording today's discussion for use online and to share with clinicians. So your continued attendance on this call serves as consent to the audio and video recording and its distribution. Our format for today includes 2 presentations, each followed by Q&A from the attendees. We encourage you to submit questions via the Q&A feature at the bottom of the screen, and we will work to incorporate your questions into the conversation. We have a lot of exciting content to cover, so let's get started. Dr. Estner will start with her presentation, and Dr. Jakobsen will be moderating the Q&A. So without further ado, Dr. Estner, thank you.
Katie, thank you very much for that nice invitation, and I really appreciate to present our experience with inHEART in the next 10 to 15 minutes. Let me share my screen with you. So hopefully you see now the presentation mode. Perfect. Then I would like to start. So we use inHEART in pretty much every VT patient we have. I will show you why, and I was asked to present that and illustrate that by presenting some clinical cases. So I'm working at the Ludwig-Maximilians University in Munich. That's one of the 2 hospitals that are located in Munich, Germany. We have 2 locations where EP procedures are performed. So the hospital that is larger is Großhadern with over 1,100 beds in 31 departments, over 40,000 inpatient cases per year. And in the Innenstadt location, focusing more on semi-inpatient and outpatient cases. And we have an experience now of around 150 inHEART cases. And I will show you the impact of inHEART in the last years. So we started in the year 2022 with inHEART, and you can see here in only few cases. We clearly stratified to run it only in ischemic VT patients, maybe even only in those where we failed in the first procedure or someone else failed in the first procedure. And we just try to get some impression how we can work with these images. And then self-explaining, let's look in the last year. So we doubled, we threefold more patients with inHEART nowadays. So in this year, we have around 60 inHEART cases already performed. And I would like to start with the first case because I was asked also to present how we use it, and maybe the most difficult question always how to merge these images in daily clinical practice. So let's get started with a patient that was a male patient, 66 years of age, ischemic cardiomyopathy, severely impaired left ventricular function. And in another hospital, an ICD was implanted in November of 24, and he was admitted to our hospital right at New Year's Day. And I will show you afterwards the ICD report. And as you can see here, he had many, many VTs ongoing over these days. The clinical course after LVAD implantation was a little bit complicated, as I stated here, with intestinal ischemia. But he recovered relatively well after implantation of the LVAD, and he already went at home. And he was intended to go and start his rehabilitation. But 1 week before that, he came back with many, many VT episodes. And I will show you the ICD report. So this is the ICD report before LVAD implantation. You see in December, really a bad day with many, many VTs, many shock deliveries. He got an amiodarone on Maxetil. And as I stated here, really New Year's Day, 3rd of January, not really the best colleagues or the best man on place, and he got a high urgency LVAD implantation on 3rd of January. And then he recovered quite well. But I show you here the report of the ICD from February until he was admitted again, with again many VTs. Most of them were ended by 1 ATP, but also with shock deliveries. And in total, he had 34 slow VTs and close to 600 fast VTs. When he was presented to me if I want to ablate him. And you should remember that number because I will show you afterwards the follow-up of the patient. We run an inHEART, and as you can see here, this is something what we expected. We see the LVAD, you see the bypass tract from the LVAD to the aortic groove, and you can see the huge lateral wall infarct also here with calcification that is illustrated quite well in inHEART. We merged the images using the ICD leads and the LVAD itself, and we went for ablation by just using the MAP catheter. We did not perform any electroanatomical mapping in advance. We just go to the inHEART and then modified all the channels. But if I show you the electroanatomical mapping itself, it's really not the nicest image I would show in a presentation, usually showing VT ablation procedures, because you see it's really rudimentally. We only have a impression of the left ventricle, but if we overlay it with the inHEART, you can clearly see where we have been. You can clearly see where the channels are. And you can imagine why we went there and why we spared, for example, the part close to the insertion of the LVAD. And the procedure was really very straightforward, no complication. We could induce in advance of the procedure. The patient was not inducible afterwards. And the clinical course is self-explaining because here in October of 25, not one single VT anymore, not the slow one and not a fast one. So a really helpful modality to use for such a patient. But the merging, of course, is for beginners. If you have an LVAD and you have to merge the inHEART CT, that is really easy. The second patient is a little bit different. That's a patient with a congenital heart disease, a young female. And her clinical course is really interesting. She got a corrective surgery at the age of 6, but she had a really bad clinical course afterwards. She was resuscitated. She had a reoperation, acute renal failure, bleeding, liver dysfunction, hypoxic brain damage. So a really complicated clinical course afterwards. With the age of 14, she also get a second allograft replacement, and the residual VSD was closed. But interestingly, she still had a very, very impaired biventricular function. Not only the right ventricle was bad, but also the left ventricle. And she was admitted to our hospital because of recurrent VTs, low VTs. And the admitting hospital also tried medication, and she was admitted. And in the following 24 hours to our hospital, she already got 4 episodes looking all like that. So many ATPs. Here in that case, the ramp terminated the VT, but there have been also VTs that could only be terminated by an ICD shock. And I said, because it's a congenital heart disease and she was reoperated and I want to see where the calcifications are, I wanted a regular CT. But as my fellows only know inHEART CT nowadays, unintentionally, an inHEART was run. And I will show you the result of the inHEART. And first of all, so you see here the right ventricle, you see the PA right ventricular conduit. You don't see calcifications there. That was a little bit surprising for me. But the most surprising fact was this huge anterior wall infarct in the left ventricle. And in the beginning, there was no explanation for that. So we went through all her OP reports, operation reports, and in this report, when she was operated the first time at the age of 6 with this bad clinical course, we found the resolution because, and the explanation, the LAD during that operation was accidentally closed. And it was reopened 3 days later in the reoperation. So we have clearly an LAD infarct. You could say, well, if it had been documented better, then you would have known that. But I can really tell you, we didn't know that. And the treating physicians didn't know that either. So it was really surprising, but it clarified a lot. So how did we run the procedure? As you can see, as the ID stated, it was one of the earlier cases, and we did the merging by doing electroanatomical mapping of the right atrium and a little bit of the left atrium, and then we got the merging for the left ventricle. We went for ablation right here in the left ventricle. We induced her, and we could really make clear that the VTs come from the left ventricle, not from the right ventricle. We used an octapolar catheter because I wasn't sure for that. So I was really focusing on mapping the VT2. So we induced it. And you see here the location of the octaray catheter in the left ventricle. You can see here the electrograms of the octaray catheter, when you can clearly imagine that this is most like the right spot. So once you move the heart looking from superior in that region, and here showing you all the octaray signals, you can clearly see that this might be a very interesting region. And if you have the inHEART image here, it's right at the end of one of the channels. And we got there, we ablated there, and we got rid of the VT. So very helpful in that case, and it clarified really very much the clinical course of the patient, and of course it helped to go for the VT ablation. Until then, the patient is still arrhythmia free. The last case is a case that is pretty clear for inHEART. So a 3-vessel disease patient with an impaired left ventricular function at the beginning of this year, coming here and presenting here in cardiogenic shock. He got an impeller, he was recanalized, he was stented in the LAD, but surprisingly the VT didn't cure, so the VT came back, and then I was asked to ablate him. So in this case, we did the merging using just UniView, as you saw here, and then we used the ICD leads and just an electroanatomical mapping of the aortic groove. And that is then enough to have an exact impression where the left ventricle is. And as you can see here, it was also a huge inferior wall infarct in that patient, the older one. And I tried to treat all the channels, but also I modified the border zones, though of the scar. So treating here. And in that region here, I realized that I can't really get a high contact force. I realized that PVC that always came from that spot, but it was somehow difficult to reach. And the explanation for that is that right in that spot, the papillary muscles were. And it's so easy with inHEART to visualize that. And once you understand that, then you can change your ablation strategy. And I modified here a larger area. And after that, I really was able to treat the PVC itself. And this, I would say, wouldn't be, maybe I would have reached that also just by a regular VT ablation. But once I realized that it's a papillary muscle, it makes a change in my mind, and I changed to focusing on a larger area. And then, at least in this patient, it helps a lot to get rid of the PVC. So I want to, oops, that was fast. I want to summarize how we merge the inHEART at our hospital, and that is not so easy to answer because I don't have a clear answer to you what the best modality is, but I really like to use UniView, and then I use some electroanatomical landmarks that I get anyway. So for example, the leads of the ICD, maybe even if I don't have that, I use the CS catheter, and I try to do a map of the CS very briefly. And what helps a lot is also doing a map of the aortic groove, but then you really have to focus to treat all or to reach all cusps. So really a 3-dimensional image, knowing exactly where the right coronary cusp is, where the main coronary artery is. And if you intubate the main coronary artery just a little bit, then it's very easy to move the inHEART exactly in that location, and then you have maybe the best merging. If that doesn't work, you can also use an angiography of the aortic bulb. But the difficulty is here, then you have to exactly choose where the end-diastolic phase is, because otherwise you have the shift of the systole. just doing a map of the aortic roof might be also sufficient. So maybe you don't even need the leads, but I don't have really the one answer. So I even have some patients where I still do nowadays a map of the left ventricle to make sure that the merging is really done quite well. So in conclusion, I can say at our hospital, we use inHEART for pretty much all substrate-based VTs. We merge it with anatomical structures, as told you on the last slide. And in our opinion, it shortens the VT procedures. But as VT procedures are so heterogeneous, it's so hard to tell how much time we save. But for the operator, it makes the ablation target much clearer. And if you don't want to induce the VT, you can go just for checking if you have really exit block along all channels. And once you have exit block along channels, my experience is that usually after that, you won't be able to induce the clinical VT again. And last but not least, it helps also in visualization of the relation to other anatomical structures, like, for example, the papillary muscles that I showed in the third case. Thank you very much.
Thank you very much, Dr. Estner. That was a beautiful and very clear presentation and some very nice cases. I'm from Copenhagen, and we also do a lot of VT ablations. I would like to discuss a little bit of you both, the pre-procedure planning and use of the inHEART system and the intra-procedural strategy based on inHEART, and maybe also touch upon a little bit on the visual or evaluation of the effect of the ablation. So again, coming back to one of your points for the selection of patients and when to do inHEART. You say that you're doing it in all patients when you do a substrate-based ETs. But
yes.
How do you then? Is it then all your VT patients? What if you don't know what if there's a substrate or if it's a non-substrate based? Do you inHEART on all and then decide whether it's a substrate-based strategy, or do you select upfront and then do the inHEART?
Mm-hmm. So we have a handful of patients where we run the inHEART, and then inHEART stated there is no substrate. Yeah. Of course, I mean, we have some patients with fascicular VTs, and then you don't see anything in inHEART, but we have the inHEART image, and we just make that clear that we don't see something there. We use it also in the right ventricle. In the beginning, I thought it wouldn't help me a lot, but I realized that I somehow underestimated how large in some cases the right ventricle really is, and how difficult it might be to really reach and treat the anterior part of the right ventricle. So even if I can use the channels of the inHEART, then I see the anatomy and I can see the fatty impact in the right ventricle, and that helps me also a lot. So not only ischemic VTs, this is why I stated all substrate-based VTs. I also run it in dilated cardiomyopathy, not always seeing something, but just making sure that I don't oversee something or something that could help me.
Yeah, excellent. And I will now, I can follow the Q&A from the audience. And there's a question from the audience stating, is UniView a vendor-specific software? And I mean, you can answer that, or we can discuss. But can you answer that, please?
UniView is J&J software, and it is a combination of the fluoroscopy unit with the 3D mapping system, and you have to register the magnet of the of your patient laying on the table with with your fluoroscopy unit. And once you have that, then you can always overlay the fluoroscopy image with a 3D mapping system. But it's really unique for J&J, and I can't answer if any other company has such an software package. I don't know. I don't think so. I think it's only unique for Carto and J&J.
Thank you. Okay. I would like then, so now we've discussed a little bit of the pre-procedure planning. And maybe I would like to ask you also, do you find inHEART useful in defining endo versus epi substrate? I mean, there's several features, scar heterogenization, wall thickness, endo epi, the percentage and all. Is it useful for you upfront to decide whether go epicardial or not?
So in truth, I have to admit that once I have inHEART, that I usually stay endocardial for the first procedure. And the results are so good that I don't see the point to change that in advance and go right for epicardial approach in the first procedure. So in my eyes, I don't use it really for stratification, because I always go the first time only endocardially.
Mm-hmm. And that goes both for ischemic and non-ischemic patients?
Well, in non-ischemic, it is slightly different, because inHEART, of course, does not tell you. So the channel localization is different, and I think Dr. Schauble afterwards speak a little bit about that. I mean, for ischemic VTs, that is pretty clear where the channels are. But in dilated cardiomyopathy, it is completely different. And we always also have cases where we don't see pretty much the target in inHEART. So there it's different. But for ischemic VTs, I stay endocardially for the first procedure.
Thank you. There's also another question from the audience. That's a very specific one. If you have recommendations when you register inHEART when you're using the Affera mapping system. So that's a newer PFA system from Medtronic.
Yeah, here I can't help yet, because I hope to get Affera in January, and I can answer this question maybe then in March or something like that. But nowadays I don't have any experience with Affera. Sorry.
Oh, yeah, that's a good answer. Okay, so then now we are going from pre-procedure to inter-procedure strategy. What about, have you any advice or experience in using inHEART also to repeated CT scans and inHEART measures to evaluate the effect of the ablation? Is that possible, do you think?
So we have a handful of patients where we really run a second inHEART, just because the first inHEART was some years ago, and there happened something in between. For example, we had a patient where the VT was, the mitral valve was clipped, and it completely changed the anatomy of the left ventricle by clipping. But I don't have experience in series where we repeated the inHEART CT. No, we don't have that.
Mm-hmm. And I'm also very interested in your strategies. In at least one of the cases where you relied completely, that was the first case, on your inHEART model and did not do any 3D mapping and just ablated. And is that now your general strategy to not verify with electrograms or late potentials or other substrate? You go straight for the inHEART
No, usually.
distance.
No, usually not. So usually I do a map, and I usually still use an HD mapping catheter. So I still use the pentaray or the octaray catheter if I can. But in the LVAD, of course, I don't want to use that small catheter, so I only have the mapping catheter, just for fearing that I go in the LVAD itself. But usually I do a map, at least confirming where the scar and the border zones really are. So I think you can focus on the scar, but you have to make sure that the merging is really good, because in some cases it doesn't work as well as I showed in these cases, but usually it does. But still, I really make sure that the voltage map confirms the infarct.
And my last question to you is then, have you ever performed an inHEART scan and then decided not to ablate?
Yes, we have one case where the inHEART, it's a pity that I don't have it right up here, because it was a completely destroyed left ventricle. And we had not only one VT cycle length in the ICD query, and it was a young patient, so it was clear that he will go afterwards in the high urgent heart transplant, and I skipped the ablation procedure.
That's an excellent point also, that it really has consequences up front to have a clear visualization of the substrate and scar.
Yeah.
Thank you very much.
Thank you, Dr. Estner, for your great presentation. If we could have you stop sharing the screen now, because we'll be bringing Dr. Hsia's presentation up. And thank you so much, Dr. Jakobsen, for leading a lively Q&A discussion. We are now going to switch gears, and Dr. Hsia will be presenting with Dr. Wu, leading the Q&A. And again, thank you for providing your questions in the Q&A. And perhaps, Dr. Hsia, when you are done with the presentation, if it's appropriate, we'll stop sharing so we can come to full panel screen during the Q&A discussion.
Okay. Can you hear me? Can you hear me?
Yes.
Okay, so I will go ahead and share my presentation. Okay. Can you see me?
Perfect.
Okay. Anyway, my presentation will be a little bit different. We'll talk about little historical aspect and current status, and also the future directions. So basically, okay, let's see. Okay, so basically, the inHEART imaging technology, we've been using it since 2000, about 2017, 2018. But historically, imaging-based VT ablation has evolved for many years. It started with subendocardial surgical resection, and dated back in the 1980s. And so the surgeon, pardon me for these black and white pictures, but back in the 80s at the University of Pennsylvania, the surgeon will go in and take out, this is a left ventricular apical aneurysm, and a bigger imaging, see that the surgeon will actually open it up. We know that the VT circuit resides around the dense scar, at the border between the dense scar and the normal tissue. And the surgeon will come in and actually cut open the aneurysm. You can actually see visually that you can see there's a white fibrotic tissue here. That's a dense scar. And then the darker tissue are the normal the normal myocardium. And so this is a subendocardial surgical resection, and the long-term success rate is actually very, very good. So this is there are several studies looking at the influence of mapping and the surgical ablation outcome, and clearly the more VT you map, meaning that traditional mapping with the EP techniques, the better the long-term survival of the long-term success of the ablation. And when I say success, meaning that no inducible arrhythmia of any type for the next 10 years. So that's really, really pretty good. But most importantly, even when there's no mapping, when the surgeon just look at it and visually inspect the scar, they're still, just without mapping, just by looking at it, we can achieve almost 60% long-term success rate. And that's really quite phenomenal if you think about it. And this is really the basis of imaging, or at that time, it's a visually guided approach for substrate characterization and VT ablation. And that forms a foundation of what we are doing for the last 20 years. Of course, with the advent of electroanatomical mapping and voltage characterization, we can see there's a big scar, and then we depict the VT circuit as if this is a large scar with big swabs of non-conducting tissue and channels. And that's what we think that the VT circuit is. But in reality, the VT circuit is mostly functionally defined. So I will talk about a little bit about that. But anyway, you can see that there's a big scar here with a red dense scar in the border zone in the normal tissue, and everybody's familiar with the voltage color display. And you can overlay it where the VT circuit would have been, or presumably would have been. And then you can actually prove that these are actually isthmuses. You can identify isthmuses and exit in the outer loop. You can look at the local voltage profile at these sites defined by entrainment. And clearly, most central isthmus are in the dense area, less than 0.5 millivolts. As a matter of fact, they're usually around 0.2 to 0.3 millivolts. And most of the exit are near the border zone, around the 0.5 or so. So based on these, you can say, okay, if I can visually, again, using some sort of voltage guided color imaging, that you can correlate the so-called VT channels, overlaying the functional component of the VT circuit. Now, more recently, obviously, we actually use either cardiac MRI or CT scan or even PET scan for cardiac imaging, and that has been part of our clinical management for the last several years. And imaging turns out to be very important for not just for diagnosis, but for prognosis. And we know that for ischemic patients, the MRI has identified the infarct-related VT. There's a dense scar near the subendocardial layers. And then, but there's also a so-called a gray zone, which is a heterogeneous tissue characteristics around the dense scar. And turns out that the size of the gray zone, or so-called kind of ischemic, or that's where the VT circuit generally resides. And then the size of this area correlated very well with the future arrhythmia recurrence risk. And for non-ischemics, the same thing happens, that if the VT, here is a MRI that identified the mid-myocardial mid-septal scar, and turns out that if for non-ischemics, if you have fibrosis identified on the MRI, you really are not going to have a very good prognosis, and the risk of sudden death or border sudden death is much higher. Especially if you have mid-wall fibrosis, the hazard ratio is almost 5. And so the imaging, cardiac imaging nowadays has both has significant prognostic information. And here, obviously, with a more advanced contrast-enhanced inHEART technology, using wall thickness as for ischemic disease. And you can see that in this particular patient with a inferior infarct, they're actually heterogeneous wall thickness that you can almost imagine that there are some conducting channels based on various different wall thickness. And that helps you to look at where the potential VT circuit could have been or might have been, and also provides detailed anatomical information on other cardiac or non-cardiac structures, and which becomes important when you're considering doing an epicardial procedure. And so the imaging are, not just for ischemic disease, but also becomes very important when you look at a better diagnosis for, what is a true substrate of the VT circuit. And this is particularly important in patients with non-ischemic cardiomyopathy. And before using the cardiac MRI, using the traditional cardiovascular diagnostic tools, it was echo and catheterization technology, catheterization, and before the cardiac MRI, we in this particular study, and you can see that 54% of a patient that was deemed to have no structural heart disease before the MRI, and 7% had what we called was defined as a non-ischemic cardiomyopathy. But after cardiac MRI, that significantly changed the diagnosis, and actually so for diagnostic purposes, especially with non-ischemic cardiomyopathy, cardiac MRI is really quite essential. So after using the cardiac MRI, the diagnosis of non-ischemic cardiomyopathy increased from 7% to 24%, and patients who previously thought had no structural heart disease decreased from 54% to 33%. So in total, about half of the patients, in patients without coronary disease, in half of the patient, there's a change in diagnosis. And so that provides significant, important information in terms of what kind of substrate you're really dealing with. And if the cardiac MRI is not available or not of good quality, you could use, contrast, iodine contrast, enhanced CT scan. And this is a patient with a non-ischemic cardiomyopathy, and he unfortunately had both, actually there are two predominant patterns of non-ischemic cardiomyopathy. These are very common patterns. And the non-ischemic cardiomyopathy patients the scars are usually perivalvular near the base. And there's about a 50-50% distribution. About 50% of patients with a lateral LV basal scar that are mostly epicardial. And you can almost see that there's a endocardial surface and there's an epicardial surface. And then so the lateral LV scar or near the base or the mid ventricle tend to be more epicardial. And unfortunately, the other 50% are usually perivalvular, periaortic near the basal septum, and they are usually intramural. And this is important because of, obviously for pre-procedural planning, if you have a non-ischemic cardiomyopathy, and turns out that 50% of the patient, you will not benefit from epicardial ablation because obviously for the patients with a mid-septal scar, epicardial ablation will be extremely low yield. So these are for non-ischemic cardiomyopathy. I think that preoperative imaging is particularly important. And then for ischemic cardiomyopathy, the CT-guided wall thickness imaging is important. So therefore, the current guideline from the various different societies, the consensus statement for catheter ablation of ventricular arrhythmias endorses the pre-procedural imaging. It has a class 2A indication for diagnosis, for and identifying the potential arrhythmia substrate, and also for procedural planning. And so these are 2A indications for both ischemic and non-ischemic cardiomyopathies. So I will just go ahead and present a patient. He's 76 years old. He has multiple infarct, had a cabbage, and lousy heart, had a CRTD. He initially presented was 2010 with VT, had an ablation in Texas in 2010. And I did this one in 2011 when he was at the VA. And so I did it 2011, has 7 VTs. He did very, very well, actually, until about 10 years later. That's usually the case. They usually do very well. And then 10 years later, when the substrate further evolves, and then sometimes they come back after 10 years. And this time he presented with a lot of VT, with multiple storm, refractory to high-dose amiodarone and mixilotine. So I took into the lab actually quite a few years ago. The eyes showed a very big scar, and from the infraposterior LV all the way from base to the septum. And he unfortunately had incessant multiform VTs just with catheter manipulation. And the VT was refractory to RV, LV, BIV pacing and multiple shocks. And he basically arrested with a YQRS, widening of the QRS and recurrent VF, VT-VF. And basically he coded on the table. We eventually got him back after about 10, 15 minutes of CPR. He got an emergent cath that didn't really show anything, any new culprit. So we stopped the amiodarone because sometimes high-dose amiodarone in these patients actually causes the arrhythmia become more unstable and difficult to map. After a few days in ICU, he came back for a second ablation. So this is our first ablation. You can see that he keep going to VT. We pace him out. We try to pace him out, but he just reinitiates right away, and then so it becomes a totally unmanageable situation. So we got a CT scan. We're looking for wall thickness, and you can see that he has a very, very large, dense inferior infarct that pretty much a scar that involves the whole inferior left ventricle. And the septum is relatively spared. You can see that the wall thickness, there seems to be a mitral annular channel here, but if you look at carefully, there seems to be 2 channels that goes along on either areas, maybe here. So the second time we brought him to the lab, same thing happened. He, was very, very irritable. He just kept going to VT even with any sort of catheter manipulation without, we didn't really get to map or do any stimulation. He just kept going into it. But you notice that there are 2 predominant morphology. There's a left bundle, left superior VT, and what appears to be a right bundle, right inferior axis VT. But if you look at it carefully, that the first one is a left bundle, left superior VT was a decreasing R wave. So this is a septal mid to apical LV exit. And you can see that it is the initial QRS is superiorly directed. Even with the second VT, which is a right bundle inferior predominantly in the inferior leads, but if you look at carefully that the QRS actually does start with a Q wave. So therefore, this is again the initial activation is again superiorly directed, except this one exiting more in the mid to apical LV laterally. So we didn't really do much electroanatomical mapping. We bring the patient to the lab. We usually registered the CS and the aortic valve. We couldn't do a lot of more registration because he was too irritable. But you can see that based on the inHEART CT with the wall thickness, that these 2 potential channels, and which is consistent with where the exit is. So this one, the left bundle, left superior is exiting from the septal mid LV location, whereas this one is a right bundle, again, actually superiorly directed, is exiting in the mid to apical, is probably the mid LV laterally. And we put the catheter right to this area, and you can see there's a bunch of late potential or lavas, should I say, that was recorded. And then by putting the catheter, we didn't use high density mapping because of irritation. We just put a catheter where we think the money is. We did some pacing. You can see that this is a very short stimulus to the QRS, even though it's not exactly the same, but it has all the right, right overall axis morphology. So this one is probably near the exit. And then we go into the channels here by putting the catheter here along this potential area, and you can get a long stimulus to the QRS. Again, although not exactly the same, but again, that some of these morphological changes may be related to rate, and so this is at least suggestive. We have slow conduction out of this location that's into the exit area. So we started doing empiric ablations, and then we go back to look at the more septal areas. You can see that they are progressively delayed late potential in sinus rhythm. By changing the wavefront of activation, you can actually bring out the lavas a little bit better, and they are progressive delay into the channel. So we can see that there's in sinus rhythm or doing pacing, you can see there's a progressive delay into this channel, and then there's progressive delay exiting out of the channel. Then we start doing some ablation, and the VT become more manageable, and he's no longer extremely irritable. We are able to the VT slows down a little bit and actually becomes only a single morphology, and then we're able to map and using a more traditional technique and show that demonstrating concealed fusion, and then and then was successfully ablated. And the patient has not had any problem for the last 4 years. And this is just another example of a different patient with using the inHEART CT with so-called channel maps. And then you can see that we end up doing the ablation, and the ablation actually, by combining them, the ablation actually goes right in between these, between the dense scars. As far as the VT imaging guided VT ablation, and the meta-analysis a few years back showed that has almost 40 articles about almost 8,000 patients that showed that at least in the ischemic heart disease, if you use a wall thickness as a guide, that you can achieve VT-free survival 82% compared to 59%, and the overall survival is also quite respectable. So at least for ischemic heart disease, it's and also for non-ischemic heart disease, it has been shown to be quite useful. And now, actually, this is a more recent study looking at what we call the imaging aided versus imaging guided, meaning that you imaging guided, meaning that you just go directly to the area without performing an electroanatomical mapping. Imaging aided, meaning that you do both electroanatomical mapping and help you, the image help you to do the mapping. So it turns out that whether or not you use MR or CT, or whether or not you're talking about non-ischemic versus ischemic, they both have very good outcomes. And it doesn't really matter whether or not you use imaging guided or use imaging aided with or without the electroanatomical mapping. They both have a pretty good overall survival rate, and also the VT-free rate is about 75% in a recent study. Now, also Fred Satcher has published their experience in the inHEART European multi-center study, and the point of this study is it has I think it has 14 European centers. It's not a big number, but it's over 113 patients. But the important point is that it reduced the mean procedural time by about 30%. So which becomes important both from the hospital costs and also perhaps, if you can get the patient out of the table quickly, then the patient usually do better. So for the next few minutes, I just want to talk a little bit about, what the future direction is. And we know that from animal models that here is a VT circuit that, you can see the isochrome. The isochrome bunches up as it exiting out of the exit area. Here's the isthmus, and it goes around, and then it bunches back in again when with slow conduction when it comes into the entrance. And then so the entrance of the VT circuit is the slowest conduction with critical conduction delay, and the isthmus is relatively fast, and the outer loop is also relatively fast. So, but these features may be detected. They're topographical features or anatomical features during sinus rhythm that you may be able to identify where these locations, where the potential VT circuit or the potential critical zone of slow conduction is for the VT circuit. And that's what Rock Tongue is talking about, those deceleration zones. And you have a big scar, and then in sinus rhythm, you can see that these area bunches up. And so this is a zone of slow conduction in sinus rhythm, which correlates reasonably well with the functional component during the VT circuit, where the entrance is located. And at Chaccio in Colombia, again, in animal studies, show that here's two VTs in a figure of 8, and during sinus rhythm, the entrance of the VT is usually the latest activation. And because the activation goes in and goes around, so the latest is usually near the entrance. But the important thing is that, that these areas has topographical features or functional components that results in the slowest conduction during sinus rhythm. So these lines are the so-called the lateral isthmus boundary. But during sinus rhythm, as the activation goes around these areas, these areas has the greatest activation time differences as the sinus rhythm, as the activation comes around, especially near the entrance, and as depicted by these red colors. Now, this is in the animal studies. So we did a small study of only 6 patients with this inHEART CT imaging, but here you can see that here's the inHEART CT imaging was a dense scar or the potential channels, but we're looking at Dr. Chaccio is looking at not just the thickness, but the change of thickness or the thickness gradient, because so the greatest change of thickness based on the CT scan is depicted in this case as a blue color, and then because of the greatest change of thickness over thickness, and that means that there's going to be impedance mismatch or a source sink mismatch in this area during sinus rhythm. So these areas actually have the slowest conduction during sinus rhythm, similar to what these in animal model shows. So, and then here you can see during activation, this is where the VT is, but the lateral boundary of these area may be depicted or identified, should I say, based on the imaging of wall thickness or change of wall thickness or the thickness gradient. And then here you can see that in these patients, only 6 patients, that these lateral boundaries has the greatest change or the thickness gradient compared to other areas, including the isthmus. And here you can see there's two lines here, which correlated to the lateral boundary in this patient. And here's a patient with 2 different VTs, but you can see that at least, even though they're 2 different VTs, but where the lateral boundary is, they often share the similar topography. And then it's depicted by the greatest change of tissue gradient in sinus rhythm. So these are potential future research directions. And obviously, the next step would be some computer imaging, computer modeling or patient-specific imaging, and then you can see that perhaps you can, in a patient, you can define where the VT circuit would have been or should have been based on the wall thickness, and then you can help you to do the ablation even before you bring the patient to the lab. But more importantly, this may provide prognostic information in like which patient is going to be at risk for a future arrhythmic event. And here's the, at least in this small study, 6 out of 9 patients have a patient-specific computer simulation that creates identify a VT circuit that matches the clinical VT. So in conclusion, the imaging integration, improved diagnostic accuracy, provide pre-procedural planning and workflow, tells you where the VT is, and may even tell you what the functional component, which is about 70% of the VT circuit, and then predict successful ablation site, and maybe even provide prognostic information regarding risk stratification. All right, thank you very much.
Thank you, Dr. Shaw and Dr. Wu. We would like to open it up for those that can stay on for some Q&A discussion.
Henry, thank you for that great presentation. I learned a lot from that. So there's a lot of interest in this wall thinness. Do you find that this shortens the procedure time when you perform the procedures, or you have to perform less ablation lesions? Do you specifically target channels within the scar or the thicker areas in the thin? How do you go about doing that, or do you just circle the entire scar?
Well, what I presented as the thickness gradient, that's still an investigational procedure. What I'm saying is, we can take the CT scan, and Dr. Ed Chaccio actually will have to process that. So that's not a commercially available parameters to get. That takes a lot of computer power to try to develop that. Whether or not that will be something reasonable in the future, I don't know. But as far as from the practical point of view, like I presented, we will identify I will go into the so-called quote unquote channel area, but we will also try to correlate with electroanatomical mapping with lavas or some sort of pace mapping, try to confirm the functional importance of these channels, because there are many channels, and not all of them are important. But once we identify what are the important area, then we just try to blast everything within that channel. That's how we do it, clinically at this time. But the wall thickness or the thickness gradient or these change of thickness over thickness, those are, like I said, potentially maybe AI will help us to do that in the future. But at this point, it's not. I mean, at least as we speak at this time, that's not a clinically available feature.
How does the pre-op scan help you in planning, and does it shorten the procedure time? Does it, like you mentioned, sometimes it's a more septal substrate versus free wall?
Yeah.
Does that change your approach for doing approaches or epicardial access?
Yes, absolutely. I think it's more important for non-ischemics. So I think that it's essential for. Personally, I think it's essential for some sort of preoperative imaging for non-ischemic, because sometimes you will be very surprised at what you see. And, we normally, for non-ischemics, I will say end up 50% of the time that you don't have, 50% of the time, statistically, you cannot go epicardial because you can't deal with those peri-aortic septal substrate anyway with epicardial. So that help us to focus on the more predominantly endocardial approach, and obviously for non-ischemic, with the septal substrate, then the patient is at a much higher risk of conduction system damage during the collateral damage during the ablation. So we will inform the patient, and obviously, if, planning for upgrade for CRT, or maybe if they have a CRT, then we will be then we will that will obviously help us to decide whether or not we should focus on the septal substrate if the pre-op imaging identify where it's located. If it's lateral, then I think that we have a much lower threshold to go lateral to go epicardially, because then those areas are much more amenable for epicardial approach, especially in non-ischemics. But for ischemics, I think that as Mark Josephson has taught us many years ago, even though some of them may require epicardial approaches, but generally speaking, you can it's less than, I would say, less than 10-15% that you need. 10% you need epicardial approach for ischemic patients.
Okay. I'm going to ask a couple questions from the audience. So the first one is, how should we interpret apparent wall thickening, especially when it overlaps with the papillary muscle? And does that help you guide either the RF or PFA power delivery?
Very good question, because obviously the wall thickness doesn't really apply well to the to the pec muscle area. I think the PFA. Wow, that's a different question. The PFA in the ventricle is because the design of the form factors or the delivery catheter, the PFAs are usually still too superficial in terms of it doesn't really go deep enough with the way that the catheter is designed. Of course, there are other, ventricular specific PFA. There are a few companies that specialize in the area. But as far as the pec muscle is concerned, if it's, I think the interpretation of wall thickness in the air, I don't really rely too much on the wall thickness map. In that case, I will look at the iodine contrast enhancement, which is also available on the inHEART CT scan, because the wall thickness obviously doesn't mean much in patients with at the papillary muscle area. I'm not sure I actually answer your question, but I think that I would not use wall thickness over the wall.
Don't rely on the CT.
Yeah,
Okay.
yeah.
And another question is kind of the registration of the mapping systems. We've heard a little bit more about Cardo. How about Navix or Affera? Do you always get the coronary sinus, aorta,
Well,
valve?
unfortunately, because the UC is we don't have Affera at this time because it's a system-wide contract. But but in general, I will register. Of course, registration is highly variable, depends on different institutions. We used to register the aorta, but now we register the left main, the cusp, and the CS, and also that similar to the Bordeaux group, we will register the pulmonary artery as well. But again, it's not a great, as you know, it's not a great, it's a manual registration. So there's still some variation in terms of accuracy. So that's why I always have to go back and reconfirm with electroanatomical mapping with some recordings, and then try to further adjust the map and try to fit the CT or the MR imaging or the CT imaging usually. So it's not an ideal process, but I think registration of the sinotubular junction of the aortic valve and make sure we correct for the rotational changes of the heart try to get to the apex and obviously the coronary sinus and the PA. I think that helps to it's a reasonable results.
Great. Thank you very much.
Yeah.
I think we're kind of near the end of our time, so I'll turn it back over to the inHEART moderators
Absolutely.
to close it.
Yes. Thank you, Dr. Wu and Dr. Shaw. Great presentation and really lively, good Q&A discussion. So thank you to our presenters and our guest panelists for sharing your experience with the inHEART solution today. And to all of our attendees, we thank you for joining us. If you have additional questions, remember you can reach out to sales@inheartmedical.com. And to watch the previous inHEART webinars, which there are now nearly a dozen, please visit inheartmedical.com and select webinars from the main menu option on the top right of the screen. Thank you, everyone. Happy holidays and have a great day.
All right. Thank you. Thank you, Dr. Wu. Thank you,
you.
everybody.